stands first as far as OCP is concerned and has a very minimal role as far as SJS is concerned. And in these patients, if you have any doubt regarding the diagnosis or the management, it is best to refer these patients to a tertiary eye care where the condition can be taken care of adequately, because a suboptimal treatment in these patients always ends up with complications. So I think with this, I will just skip through. Some of these slides that I just wanted to show you was how adenoviral conjunctivitis can mimic a patient of OCP. This is a sebaceous gland carcinoma that ultimately required exenteration, which had been diagnosed as OCP elsewhere. And with cicatrization, which was being treated with methotrexate for 6 years, but you can see how she improved drastically after the use of mycophenolate and pulse endoxin. So the take home here is cicatrization is usually not seen in patients of Sjogren's syndrome. We always categorize our patients as dry eye without cicatrization and cicatrization with or without dry eye, because the path that you will take both for diagnosis as well as management in these patients is very, very different. Of course, you can have an overlap in these patients. You may have them have a combined disease, but that's something that you will look into if they are not responding adequately to the treatment that you are offering. So in conclusion, in cicatricial disorders, I think one important thing that you need to take home is you need not feel pressurized to have a diagnosis in the first visit. You need to build a rapport with the patient, and you always revisit the history and clinical examination when things do not add up. I would like to acknowledge the entire team back home at Shankar Nethralaya and also invite you all to the OSCON meeting that will be conducted in August. Thank you.
Thank you very much for that wonderful talk, and it was a very good overview. I just had a quick question, Dr. Geeta. So other than the pagetoid spread of SGC, do you see other forms of ocular surface tumors which can mimic cicatrization?
Very rarely. It's usually
unilateral when we have to be alarmed, right?
Yes, I think OCP can also sometimes be very alarmingly asymmetric, but either a pagetoid spread of OSSN or sebaceous gland carcinoma more commonly can mimic your ocular cicatricial pemphigoid. So you need to keep that in mind, which is the reason why when a biopsy is done in these patients, a small bit is always sent for histopathology to rule out the presence of carcinoma in the eye. And it is the direct immunofluorescence which helps you in the diagnosis of the OCP per se. So every patient who is subjected to a biopsy gets subjected to histopathology.
I think that is very important.
Yes.
DIF takes all the limelight, and sometimes we can miss that.
So the histopathology is more to rule out the other conditions that can mimic your OCP, and the DIF clinches the diagnosis.
Thank you so much.
Thanks.
Any question?
While Dr. Namrata loads, I'll just ask you a question. Many of the patients with OCP also have glaucoma, and it becomes a challenge to give them steroids. And second thing is, many of them are quite old and frail, and either their families refuse or their doctors refuse giving them immunosuppression. In such cases, can we try them with something like topical tacrolimus? And steroids also become a challenge because many of them have glaucoma. So
yes, so we have a series of patients now who have this kind of a combination. What happens with this is you don't know whether it is a drug-induced cicatricial conjunctivitis or whether it is a true OCP that you're dealing with. So what we normally do is you keep them on very low dose soft steroids. If you're not able to subject them to systemic immunosuppression, topical tacrolimus is an option. But what we have realized is that if you do have the support of a good immunologist, you can initiate even 80 plus patients on immunosuppressive therapy, especially mycophenolate. And for the glaucoma part of it, you will have to communicate with your glaucoma colleagues to either subject them to a drainage device. Sometimes a trab might fail unless the superior fornix is well formed and it is a pure DIPP that you're dealing with. You can still go ahead with a trab. Nowadays, you can even consider doing a transcorneal endoscopic cyclophotocoagulation where you're not touching the conjunctiva, but then you can ablate the ciliary processes to take care of the pressure. So that is how we control the pressure. And for the cicatricial process, you can keep them on low dose soft steroids and immunosuppression, but I do agree that there are instances when they may not get cleared for immunosuppression. You just have to keep a close watch then and explain to the family the risk of deterioration.
Thank you.
So we have the final talk for the session by Dr. Namrata Sharma on management of acute burns. So Dr. Namrata, just 1 second. I would just want Akhil to brief us on one last topic before he joins his next session. So your role to pick contact lenses in ocular surface reconstruction, ocular surface disorder. So how would you prefer, which cases do you pick RGPs and which cases do you pick scleral lenses?
Divided into two parts. One with diseases which have a wet ocular surface, maybe status quo slit in a chemical injury, versus those which have a dry ocular surface, like cases of OCP. So in cases of wet ocular surface, we can still try a rigid gas permeable corneal lenses, provided we will be able to achieve a good fitting in them. Otherwise, over time, it can lead to epithelial defects and it can lead to other complications in the future. But if we can achieve a good fitting, then what the data has shown from our institute is that they are very good choice, both the corneal as well as scleral lenses, especially in cases after SLED. We have shown that at least there is 6 Snellen lines visual acuity improvement in around 30% of our cases, and in around 85% of our cases, there's an improvement by at least 2 Snellen lines. Now, when it comes to cases like OCP or surface or cases in which there is a very compromised and a dry ocular surface, corneal rigid gas permeable lenses are not a good choice. In those cases, we prefer to use scleral lenses, which provide not only good visual acuity, but also have a very good comfort in these patients. And the patients do very well with these lenses. They have a very good vision with them, and they are also comfortable. But of course, with the scleral lenses, there is this problem of midway fogging, which is nothing but deposition of turbidity and proteinaceous materials, which will lead to blurring of vision. So they'll have to remove it every 3 to 4 hours, and again clean the lens and put it back again. We have seen in also many of our cases that we do a cataract surgery in very compromised corneas. We leave them aphakic and we still give them scleral lenses, which again has a very good visual outcome in these patients.
Thank you, Akhil. I think scleral lenses really changed the way we manage these patients. So, Dr. Namrata.
Thank you. Thank you, Dr. Rishi Swaroop and Pragnya, for making me a part of this session. And I would be talking to you about management of acute ocular burns. This is something I think which all general ophthalmologists should know, because this is an emergency in ophthalmology. So most of the cases, almost a third of the injuries are due to chemical burns as far as the burns is concerned, and it could be alkali or acid. In our country, lime or calcium hydroxide is the commonest cause of ocular burns, although ammonia is the most serious amongst alkalis. And as far as acid is concerned, it is the sulfuric acid which is most common, although hydrofluoric acid is the one which is most severe. So way back in 2006, we did publish about the severe ocular injury resulting from tuna packets, which is responsible for most of our cases. And in these cases, it is important to know that adults actually consume this tuna, which is calcium hydroxide. Children play with it, and as soon as this bursts into their eyes, it can cause bilateral burns like this. Most of the cases who were from this cohort did not yield to medical therapy, and so had to be surgically dealt with, and they had poor visual prognosis. So as far as acute ocular burns is concerned, there could be symptoms such as pain, watering, photophobia, blepharospasm, conjunctival inflammation in the form of hyperemia and chemosis, epithelial defect, and stromal haze, as can be seen here. Then there can be perilimbal ischemia, particles in the conjunctival fornices, and decreased best corrected visual acuity because of the epithelial defects as well as the stromal haze. Then in very acute cases, there can be corneal perforation, anterior chamber reaction, increased IOP and adnexal damage, or maybe even infection if it comes to you later. Now, earlier we were dividing based on the limbal ischemia and the corneal involvement, these various burns into grade 1 to grade 4 based on the Roper Hall classification. However, it was soon realized that grade 4 has to be split into 4, 5, and 6 because the severity is different and also because the prognosis is different. So now we are following this classification, which is Dua's classification, where severity is graded from grade 1 to grade 6. The immediate medical management of a case of acute chemical injury consists of irrigation of superior and inferior cul-de-sacs with the isotonic saline or normal saline with bicarbonate or with ringer lactate or with BSS plus, whichever is available. It is important to sweep the furnaces with a glass rod. Irrigation should be done for at least 20 minutes with 1 to 2 liters of fluid. One can remove the foreign body, which acts as a depot for chemical, and use dry litmus paper in the inferior cul-de-sac. Test the pH 5 to 10 minutes later, and the pH should be between 7 to 7.3. So I think if you ask the management of acute chemical injury as such, this sums it up all along with this slide, where in the early acute phase you have to give preservative-free artificial tears, topical steroids, ascorbate, citrate, which is given 2 hourly, then topical antibiotics, topical acetylcysteine, which is given QID, cycloplegics. Some people also give autologous serum, and oral vitamin C does help, 500 milligrams in QID doses, and of course anti-glaucoma medications if and when required. Now, steroids are given in the initial 7 to 10 days period, and they do reduce inflammatory cell infiltration, and after 14 days it is medroxyprogesterone which replaces the topical steroids. Autologous serum has been shown to have concentration which is similar to tears, and some of the factors like epidermal growth factor, TGF-beta, vitamin A, alpha-2 macroglobulin are much more as compared to the tears, and they have similar pH and osmolarity, and so it does help in healing of the epithelial defects. This is our publication where we looked at the role of cord serum, umbilical cord serum therapy in acute ocular chemical burns, and we divided them into 3 groups. The cord serum was obtained from the umbilical cord blood after direct cannulation, centrifugation, and storage at -4 degrees centigrade. And if you see the various groups, auto serum did better than artificial tears, but cord serum was significantly better than auto serum as well as artificial tears both. And these are the pictures from the same study, cord serum, which does heal very well as compared to autologous serum, whereas there is some amount of haze which is there, and as compared to the artificial tear group where there is limbal stem cell deficiency as well. Amniotic membrane transplantation has an important role to play because of the pro-epithelializing, anti-inflammatory and anti-fibrotic activities, and the 2 randomized control trials which were done by us at our center clearly showed that there was faster re-epithelialization, especially in the moderate cases, and the discomfort was also less. This is just to show how washing of the ocular surface is done first, followed by the application of the glue, and this is a total epithelial defect in this case, and the amniotic membrane can then be pasted onto the entire cornea as well as the bulbar part of the conjunctiva. ProCera is something not available here, but essentially is a ring with the large ring with the amniotic membrane and keeps the fornices away. And so the fornices are actually, there's no symblepharon formation, and it prevents this by the application of this ring. Now, this is just to show that every single piece of the tuna which is there should be removed, should be washed completely, followed by amniotic membrane transplantation, because otherwise that can act as a depot from where the tuna is getting released. This was the intrastomal calcium hydroxide which was embedded in the corneal layers, and so a lamellar graft was done, and it is important that tuna is removed from these cases, and this was a tuna which was there inside the anterior and impinging the angle, and so a full thickness corneal transplantation was done. We also did a study to compare cord serum, amniotic membrane and standard therapy in retrospective study, and found cord serum to be the best, followed by amniotic membrane, followed by standard care, and subsequently did a prospective randomized study and again found that cord serum was better than amniotic membrane. The advantage is that you're not doing a surgery in these inflamed eyes. You're just putting drops, and the results are better than an amniotic membrane transplantation. Of course, there are newer modalities like amnion extract, topical Avastin, ACE converting inhibitors, topical autologous platelet-rich plasma, which have been tried, and surgical management, especially in acute cases, may consist of tenoplasty. At times, you may have to do tarsorrhaphy and use tissue adhesives if there is a perforation, or tectonic keratoplasty if there is a melt. Now, this is publication again, a very important cohort. There were patients, 14 patients, 16 patients had 31 eyes fell into a ditch of sodium hydroxide, and all of them followed up at our center 1.5 days later. So, and we know how the chemical injury is going to behave, even if you do everything possible that is required. Now, this is a publication which is done by Geeta Iyer, Alloslet and acute chemical injuries, and they have looked at Alloslet versus amniotic membrane transplantation in a retrospective study and found that it tends to have good results. This is the cohort I was talking about where accidental sodium hydroxide injury occurred. So some of the cases did do well, in others there was perforation, in some cases there was infection. We had to do everything, SLET, KLAL, even tectonic keratoplasty in these cases. But these cases do well if they are treated appropriately. And this is our publication on 114 children, 134 children who had tuna packet lime injury or chemical injury, where lime was the commonest in most of the cases, and the prognosis was generally dismal. So to conclude, early meticulous management is necessary for management of acute ocular burns. Medical therapy, cord serum, amniotic membrane transplantation, and Alloslet have a role to play in acute ocular burns. And of course, like we always say, as ocular surface surgeons, ocular burns are better prevented rather than cured because the prognosis is not that good. Thank you very much for your kind attention.
Thank you so much for sharing that huge body of research that you guys had done on chemical burns. So Dr. Namrata, I just wanted to ask, so cord blood serum seemed to be very good in these patients, but were there any adverse effects that you had seen, or was it very well tolerated amongst?
No, as far as the adverse events, I don't think there were any. It was quite well tolerated. I would say it is well tolerated as compared to auto serum also, and the concentration is 20% cord serum that we used. The only problem is the availability at various centers. So you have to liaison with some, center where gynecology department is there.
Thank you so much, Dr. Namrata.
Do you advise for all grades or depending upon the grade of burn you advocate? And is there any difference between a dry AMG and wet AMG?
So I think as far as the efficacy is concerned between dry and wet AMG, there's not too much of a difference. We've done with dry AMG also, only the handling becomes a little different because that feels more papery than a wet AMG, which is more elastic. So that is there. And as far as the amniotic membrane is concerned, amniotic membrane is best suited for cases which are moderate to severe. So from grade 3 onwards, I think it is best to use for those cases.
As early as possible after the chemical injury.
Yeah.
But availability of cord blood is
Cord
as far
blood
as
was
most of
found
the
to be the
institutions.
most superior, but like I said, availability may be issue. But if you can make it available, it is very much the way like you would do for autologous serum in terms of refrigeration, in terms of preparation, and even in terms of controlling the sterility of it.
Thank you.
Thank you very much. So, thanks everyone for attending this session. And thanks a lot everyone again for coming and contributing. So we'd hand over to the next session.
Good morning. We start the next competitive session, Dr. N.S. Reddy competitive free paper session. Before we start off, I would like to remind you that the time is 6 minutes. There will be negative marking in case you exceed the time, and 2 minutes will be for discussion, right? First, let me find out if all, Aja, please come. You can see. Dr. Abhinaya, Amit Prasad, Ananda Nambiyar, Sushma, Bhavna. Would you please come forward so that Kirti Reddy? Yeah. Abdul Jabbar. Abdul Jabbar. Kavya. Please come forward, please. Manaswini. Rajesh. Dr. Partha Palan. Pragya Bhattacharya. Rahul, Gayatri, Sai Karthik, Dr. Sana, please come. Dr. Srija and Dr. Uma Maheshwari. So like I told you, 6 minutes is for the presentation and 2 minutes for discussion. Anybody from the audience also can ask questions, apart from the judges sitting here. So we start off, the timer will be on once we say. Well, Dr. Abhinaya, are you ready with your presentation, please? The moment she starts talking, please switch on the timer.
Good morning, everyone. Myself, Dr. Abhinaya Dasari from Bhaskar General Hospital, and my guide is Dr. Rattar, and co-guide is Dr. Tulsi Priya. My topic is evaluation of best corrected visual acuity and stereopsis in patients with cataract before and after the cataract surgery. There was no financial implications in this study. Aim is to study the best corrected visual acuity and stereopsis in patients with cataract before and after the cataract surgery. Before going further, first let us see what is stereopsis. Stereopsis is defined as perception of depth produced by reception in the brain of visual stimuli from both the eyes using binocular vision. It is an essential component of binocular vision. Usually, it develops by 4th month of life and reaches adult level at 6 years of age. Our both eyes sees different images, and our brain fuses the image together and helps in making a single image. During fusion, similarities between two images are matched together and helps in making an image. After completion of fusion, depth perception is pursued. Poor quality of vision due to lack of stereopsis in an individual leads to reduction in work productivity and quality of life. Stereopsis less than 50 seconds of arc is considered as normal. Methodology. The study was conducted on 100 patients who were diagnosed as senile cataract in the Department of Ophthalmology, Bhaskar General Hospital, over a period of 5 months. Patients with senile cataract were included in this study, whereas congenital, traumatic, complicated cataracts along with best corrected visual acuity less than 6 by 60 and other ocular pathologies like diabetic retinopathy and hypertensive retinopathy were excluded from this study. Informed consent was taken. Uncorrected visual acuity, better corrected visual acuity, and stereopsis with glasses were evaluated using RAN dot stereo acuity chart at a distance of 30 centimeters using polarized glasses. Then examination of anterior segment and measurement of intraocular pressure was done. Grading of cataract. Grading of cataract according to LOX 3 classification, then dilated fundus examination were done. After proper evaluation, small incision cataract surgery was done. Best corrected visual acuity were evaluated 6 weeks after the cataract surgery. And this is the RAN dot stereo acuity chart, and this is the polarized glasses. Here I am examining a patient from stereopsis with a RAN dot stereo acuity chart at a distance of 30 centimeters. In results, a total of 100 patients were evaluated in the study with ages ranging from 55 to 75 years. During post-cataract surgery evaluation, the number of unilateral pseudophakics were 35 and bilateral pseudophakics were 65. Post-operatively, stereopsis improved in 97 patients from a median of 200 to 40 seconds of arc. Whereas in unilateral pseudophakia, stereopsis improved from a median of 400 to 40 seconds of arc. Whereas in bilateral pseudophakia, stereopsis improved from a median of 200 to 30 seconds of arc. Discussion. A comparative study of stereopsis in patients with various grades of cataract and bilateral pseudophakia by Vivek Anand et al. Found that there was decreased stereopsis with increased grades of cataract and improved stereopsis in bilateral pseudophakia. In present study also, there was significant improvement in stereopsis post-operatively along with best corrected visual acuity. Better stereopsis was seen in bilateral pseudophakic patients than unilateral pseudophakic patients. These are my references. Thank you.
So what is the message you want to give from your study?
Post-operatively, stereopsis were improved from before cataract surgery.
No, the gap between the two eyes also should be less because, as you said, in bilateral pseudophakia, the stereopsis is better, no?
Yes, sir.
So that would be another factor. Okay.
Are you able to hear?
Yes, sir.
I think basically, what's the new point you would like to bring out? I think what all you have brought out is something which is established already.
Yes, sir.
So what's the new point which you would like to? Maybe the only new thing was, I think, different grades of cataract, more dense cataracts, the stereopsis is less. That was the only significant point which I noticed.
Yes, sir.
Otherwise, there is nothing new in that because all these other things are a natural consequence.
Yes.
Anything else you wanted to bring out?
Along with best corrected visual acuity, stereopsis also improved in post-operatively after cataract surgery.
Okay.
Okay.
Second eye surgery should not be delayed so that the patient should get good stereopsis. So the timing of surgery between first eye and second eye should be reduced. to improve the stereopsis. That is your take-home message.
Thank you, Dr. Abhinaya. We can go ahead with the next presenter, Dr. Amit Prasad.
Good morning, everyone. I am Amit Prasad, a second-year postgraduate from Sarojini Devi Eye Hospital. The title of my presentation today is 1+1 free. So I'll be talking about a dermoid. To be more specific, I'll be talking about orbital dermoids. Orbital dermoids are developmental choristomas, which are basically histologically normal tissue at abnormal sites. They represent 24% of all orbital and lid masses, 6 to 8% of deep orbital masses, and 80% of cystic orbital lesions. They contain oily material, cheese-like secretions coming from apocrine sweat glands and hairs. They may lie latent many years before growth, but if ruptured, they might have a sudden presentation due to a secondary granulomatous inflammation. Orbital dermoids are mainly of two types, superficial and deep. Superficial usually present in childhood with a smooth, rounded, firm to cystic lesions, and usually located at orbital rim, temporally at the frontozygomatic suture. Although medially, it also presents medially. Deep dermoids present with proptosis and usually have a dumbbell-shaped extension because of its extension into the temporal fossa or intracranial cavity or sinuses of the orbital, sinuses through the orbital wall. They may cause intermittent variation in the proptosis because of its extension. To confirm the diagnosis of a dermoid, we can do a B scan and CT scan orbit. B scan will show a smooth, well-circumscribed swelling or lesion where the internal reflectivity might be variable. CT scan orbit shows a similar smooth, rounded lesion with an indentation onto the globe if it is present. Consistency of the cyst is heterogeneous due to its variable nature of the contents. Treatment of dermoids are usually a complete surgical excision in toto. Today I'll be talking about the first and only case in the world of a twin dermoid. It was a 3-year-old boy who was brought to the OPD with complaints of swelling noted near the medial canthus of the left eye, adjacent to the nasal bridge, for the past 6 months. This swelling was painless, gradually progressive in nature, and not associated with any other complaints. General examination and systemic examination were within normal limits. On ocular examination, visual acuity was 6/6 in both eyes. And on inspection, ocular symmetry was lost due to a fullness noted in the left medial canthus and mild mechanical ptosis in the left eye. This swelling had well-defined borders measuring up to 1 × 1 centimeter, which was extending from the lid crease till the medial canthus in close proximity to the medial orbital wall. On palpation, it was a single immobile mass which was boggy in consistency, and the skin over the swelling was smooth and pinchable. The posterior border could not be felt, and there was no adherence to the bone or globe. Transillumination was negative. Basic investigations were normal. CT orbit showed a single round cystic lesion in the medial canthus of the left orbit. Now, CCT orbits is not usually advised for a dermoid, but here we wanted to confirm the diagnosis because of its discrepancy in the palpation and inspection. On palpation, we noted it was a boggy swelling, and it was not, a posterior border was not felt, and transillumination was negative. So we wanted to confirm if it had any vascular involvement or any other cause of the lesion. So, but CECT also showed a round, non-enhancing lesion in the medial canthus of the left orbit with mild indentation onto the globe. So now it was diagnosed as dermoid cyst, and it was planned for an excision under GA. Intraoperatively, a modified Lynch incision was given at the medial canthus, and the cyst was identified and separated. This video shows the first cyst being removed. But to our surprise, after removal of the dermoid, another globular structure with a white smooth surface was spotted right beneath the excised dermoid. There was a second dermoid entirely separate from the previous one with no connections to the one excised. This video shows how we have discovered that there's an entire separate swelling just beneath the first dermoid. So it was carefully separated from the surrounding tissues in order to make sure that it does not rupture. And it was excised. Both these samples were sent for HPE later. This is the first dermoid and the second dermoid. This is the baby, the boy, first day post-op and 1 month post-op. The boy had a very good cosmetic result. And on histopathological examination, both the specimens showed a similar picture. A cyst lined by stratified squamous epithelium with giant cells, cyst lumen showing lamellated layers of keratin, and cyst wall showing pilosebaceous units. This confirms the diagnosis of a twin dermoid. Now, twin dermoids as such was never reported in any of the platforms, and it is quite an exciting find. And on looking back, we wanted to verify if this was an incidental finding or we had missed it before. It appears to have that, it appears to be a finding which was missed initially both by the radiologist and by us. Here, the picture shows a CT scan of a lesion in the medial orbit with two different echogenic natures, which indicates that it is a two different swellings. So I'd like to conclude my presentation saying cases like these add spice to our oculoplastic journey. Thank you.
Why was the echogenicity different in the two swellings?
So it was two different dermoids, which was like initially we thought it could be a septa in the dermoid, and then that was causing the difference in echogenicity. But it appears to have been two different swellings with different echogenic natures.
Same histopathology, same. No?
Histopathology is the same. It was a dermoid, sir.
So, very good observation and a video. So, even the capsule, there was no attachment at all between the two dermoids?
No attachment between the two swellings.
It's just that incidentally you saw there was another
just before closure, we noticed that there's another mass beneath the first dermoid.
Okay. Nice. Nice case.
Thank you.
Thank you, Dr. Amit. We'll call Dr. Ananda Nambiar next.
Good morning, everyone. I'm Dr. Ananda Nambiar, here to present before you on the topic, a study on closed globe injuries in a tertiary eye hospital in Telangana. So ocular trauma is an important preventable cause of blindness in the world, which accounts to almost 55 million cases annually. Closed globe injuries are a major concern for economic, medical, and epidemiological concern due to high risk of severe visual loss. As visual outcome is directly related to high life quality, it is therefore important to accurately predict the visual acuity as soon as the injury has occurred. Ocular trauma can be broadly classified into open globe injuries and closed globe injuries, open globe being further classified into laceration and globe rupture. This is a Birmingham eye trauma terminology system for the classification of closed globe injuries. So there are 4 types, that is contusion, lamellar laceration, superficial foreign body and mixed type, 5 grades, grade 1 being greater than or equal to 612 and grade 5 being absence of perception to light, depending upon pupillary response whether RAPD is present or absent. There are 3 zones. Zone 1, which is external, limited to bulbar conjunctiva, sclera and cornea. Zone 2, which is anterior segment structure involvement. And zone 3, which is the posterior segment structure involvement. The aims and objectives of the study were to evaluate the anterior and posterior segment changes in cases of closed globe injuries and also to find out the final visual outcome in such patients. This is a prospective observational study. All patients presenting to the OPD with closed globe injuries during the specified time period were included in the study. The sample size I have taken here is 150. All open globe injury cases and all non-cooperative patients were excluded from the study. So at the first visit, the demographic details of the patients were collected. Best criteria visual acuity was evaluated with Snellen's visual acuity chart. Color vision was tested wherever needed with Ishihara's chart. A slit lamp examination was done. Fundus evaluation was done with 90D. B-scan ultrasonography was done. Depending upon these findings, the closed globe injuries were classified according to the Betz classification system, and management of the patients were grouped as medical or surgical. Patients were followed up at 1 week, 3 weeks, and 6 weeks. So depending upon the findings, the results were compiled according to the demographic details of the patient and according to the characteristics of the injury. So first, coming to the demographic details of the patients, most of the patients belong to the age group between 40 to 60 years, that is 52 out of 150. Most of them were males, that is 118. Right eye was the most commonly involved eye. These are the various modes of injury which were recorded. Among these, the most common mode of injury was injury with stick, that is 26 out of 150. Most of the patients who presented to us presented during the first day of injury itself, that is 63 out of 150. So now coming to the characteristics of the injury. Type 1 or contusion type was the most commonly involved type, that is 124 out of 150, and type 4 or mixed type was the least commonly involved. Zone 1 was the most commonly involved, that is 71. Now, most of the patients, though they presented to us with a grade 4 visual acuity at presentation, but at the end of 6 weeks, most of the patients had a visual acuity of grade 1. Only 2 patients in the study had a grade 5 visual acuity or absence of perception to light at the presentation itself. Now, these are the various ocular findings which were recorded at the first visit. Among the anterior segment findings, the most common being corneal edema, subconjunctival hemorrhage, and epithelial defect. And among the posterior segment findings, the most common being vitreous hemorrhage and rhegmatogenous RD. These are the various clinical photographs. Now, this is a 14-year-old boy who had an injury with cricket ball 1 month back to his left eye. His best-corrected visual acuity was hand movements. On examination, there was a dense membranous cataract in his left eye. Eye was quiet, so he was planned for a left eye phacoemulsification surgery with foldable IOL implanted in the back. Post-operatively, his visual acuity was found to be 6.6. This is a 23-year-old male who had a history of trauma 1 day back to his right eye. His best-corrected visual acuity was hand movements. On examination, there was hyphema involving almost half of the anterior chamber. Intraocular pressures were 23. He was kept on conservative treatment with anti-glaucoma medications, steroid medications. He was kept under close follow-up. And at the end of 6 weeks, his best-corrected visual acuity was 624. IOP was under control. This is a 57-year-old male who had an injury with stick to his left eye 14 days back. Best-corrected visual acuity was hand movements here also. On fundus evaluation, there was a giant retinal tear involving almost 3 clock hours from 3 to 6 o'clock, and there was also a chorioretinal scar at the macula. This is a B-scan ultrasonography picture of the same patient showing a double linear echo sign, which is suggestive of a giant retinal tear. He underwent a left eye band buckle with PPV and membrane peeling silicone oil infusion under guarded visual prognosis, but post-op visual acuity was hand movements itself. This is a 55-year-old male who had an injury with wooden piece 5 days back. His best-corrected visual acuity was CF half meters. IOP was very, very high. On examination, there was a completely anteriorly dislocated cataractus lens in the anterior chamber. He underwent a right eye PPV with lens extraction under IV mantol. His post-op visual acuity was CF 2 meters. IOP was also under control. This is an 18-year-old boy who had an history of RTA to his left eye 15 days back. His best-corrected visual acuity was 660. He was managed conservatively on fundus evaluation. It showed a Berlin's edema with choroidal rupture. He was managed conservatively, was kept on close follow-up, and at the end of 6 weeks, his best-corrected visual acuity was 636. So to conclude, the most common closed globe injuries presented to us were of stick injuries in the 40 to 60 years age group, affecting a male patient and affecting the zone 1. So this visual outcome was satisfactory in such cases. But zone 2 to 3 injuries had a higher incidence of surgical outcome, and they also had a poorer visual outcome. Hence, at the time of presentation itself, the initial categorization of patients, depending upon the zone of injury, will help in identifying the patients who require severe medical attention, and hence given the poorer visual outcome in our study. These are the references. I would like to thank Dr. Padma for guiding me for this presentation. Thank you.
Why is the prognosis poor in zone 2 and 3? Can you tell us?
So because surgical cases for surgery was also more common in zone 2, 3 injuries, and they had also precedent at a later date in case of zone 2 injuries as compared to zone 1 injuries.
Posterior segment, generally they are poor because you get the scarring and all that retinal detachments. Even if you do a good surgery, the prognosis is poor. Why do you need longer follow-up in these blunt injury cases? What do you want to look for in the long-term follow-up?
Because in cases such as hyphema, there can be, if it is a long-standing hyphema, there are chances of corneal blood staining.
No,
and
there's no hyphema. Let us.
Okay.
What else?
Sometimes there can be an initial increase in improvement in visual acuity, but there can be a deterioration also.
Glaucoma is also one thing. Angle recession you have to look for carefully in these blunt injury cases.
Sir?
Okay. Angle recession glaucoma.
Yes, sir. Angle recession glaucoma.
So you have to
yes,
follow them for long-term follow-up.
yes.
Surprised to note was even in cases of Berlin's edema, the prognosis didn't seem to be very good. But I would like to seek the opinion of some of you, because mostly in private practice, whenever we see cases of Berlin's edema and we treat them aggressively, they respond very well and they improve quite a lot. But here she showed that mostly with posterior segment involvement, the prognosis is quite bad.
So if it's only Berlin's edema, then the prognosis will be good. But along with Berlin's edema, if there has been some choroidal rupture or something like that beneath, then which is affecting the outer retina, then the prognosis will be poor.
It's an important point brought out. So I think we should look for, apart from just Berlin's edema, in such cases, we should look at things like choroidal rupture and all. The next is Dr. Sushma. Have all of you loaded your presentations? If anybody has not done it, please do it so that there is no time delay. Is there any problem?
Good morning, everyone. My topic is about clinical study in patients of indirect traumatic optic neuropathy. Introduction. Traumatic optic neuropathy is a vision-threatening disorder that can be caused by either ocular or head trauma, and it is categorized into direct and indirect. The overall incidence of traumatic optic neuropathy is up to 2.5%, and indirect has a slightly higher prevalence than the direct. Direct optic neuropathy arises when the penetrating trauma, or especially orbital fractures associated with midfacial fractures, and it is frequently associated with severe visual loss and lower chance of recovery. Indirect occurs when the force of impact is imparted into the skull and transmitted to the optic nerve, and this damages the integrity of the optic nerve, and it leads to mild to severe vision loss. The most commonly affected part is the intracanalicular part, followed by orbital apex. Detection of RAPD in the presence of intact globe in a patient with ocular or head trauma strongly suggests the traumatic optic neuropathy. The main treatment options include systemic steroids and surgical, like optic nerve decompression, either alone or in combination. Pathophysiology, it can be primary or by secondary injury mechanisms. Primary is due to effects of direct trauma to the nerve, such as axonal shear, contusion, necrosis. Secondary is driven by process like neuroinflammation, oxidative stress, and gliosis, etc. Aims and objectives: to study the etiology, clinical features, visual outcome in patients of indirect traumatic optic neuropathy. Materials and methods: this is a prospective study conducted over 6 to 7 months in Department of Ophthalmology at Mamta General Hospital. My sample size is around 10 patients. Methods of collection of data, like details of age, gender, mode of injury, Snellen's visual acuity at presentation, and associated ocular complications and time of treatment were collected. Inclusion criteria are patients with history of head injury, patients of all ages, and patients diagnosed of indirect traumatic optic neuropathy. I excluded patients with previous history of ocular morbidity, past history of eye surgeries, any penetrating eye injuries, globe rupture, and optic canal fracture, and any systemic illness. My results were, it was frequently seen among age group of 30 to 40 years, and there is male predisposition. Mode of injury was road traffic accidents in majority of the cases. Visual acuity in majority of the patients was between PL positive to 660. Most of them are associated with facial bone fractures, and followed by head injuries and abrasions and lacerations around periorbital area. RAPD was present in 80% of the cases. These are the few images showing lacerations and abrasions around periorbital area. Discussion. A hospital-based prospective study was conducted in patients of indirect traumatic optic neuropathy. Demographic profile of the study showed majority of the patients were males and mostly belonged to second and third decade of life. This was consistent with the other studies. And the most common cause for indirect traumatic optic neuropathy in our study was motor vehicle accidents in 85% of cases, followed by self-skid or falls in 10%. It was observed that around 80% of the patients had injury of the forehead and facial bone fractures. This supports the pathogenesis of indirect traumatic optic neuropathy, which involves the transmission of forces from skull to the optic nerve. RAPD is present in majority of the cases, which is the consistent diagnosis. All patients had normal fundus and ophthalmoscopic examination, which show that these patients had no previous retinal or optic nerve disorders. Best corrected visual acuity was less than 660 in 60% of the cases, while rest of 40% cases showed BCV of more than 660. Conclusion: RTA is the most common cause of indirect traumatic optic neuropathy and mainly noted in young males of age group of 30 to 40 with presenting visual acuity of majority of the individuals was less than 660 and most frequently presenting with facial bone fractures, and presence of RAPD mostly confirms the diagnosis. These are my references.
So you didn't mention about the treatment and how they were treated?
Sir,
it was
I
not
didn't,
part
like,
of the study?
Yes, sir. Treatment was like many of them were non-compliant, sir. Like we started steroids only in few of the cases, and a few of them lost follow-up, sir. So I didn't focus on that area.
Also, did you do an CT orbit in all of your patients or no?
No, ma'am.
No, okay.
Like head injury patients.
Only head injury patients, because these patients do come with sometimes, as you showed the lid edema and all that, sometimes it's not very easy to even check the RAPD and all that. So how did you make sure that it was all indirect form of traumatic optic neuropathy?
Like RAPD was present, ma'am, in majority of the cases.
So main category was RAPD?
RAPD, yes, ma'am.
RAPD, okay. One point, sometimes in these optic neuropathy cases, especially indirect ones as you have shown, we don't even see any characteristics of the abnormal characteristics of the optic nerve.
Yes.
It might be looking actually very healthy to us, but RAPD is the clincher that there is something ominous going, and if we pick it up, we treat early with steroids, we can actually save some amount of vision for these patients.
And normal fundus was also present in majority of
The patients, yeah. Again, VP is another adjuvant which we can use before we start off IVMP and all that. So that helps in our decision making also.
Yes.
And we have to be quick in these cases. We can't wait for the pallor to set in the optic nerves before we plan to give steroids. Thank you, Dr. Sushma. I'll call Dr. Bhavna next, yeah.
Good morning, everyone. Myself, Dr. Bhavna, second year postgraduate from SVS Medical College and Hospital. Topic for today's discussion is clinical study of optic neuropathy. Coming to the introduction, optic neuropathy is one of the commonest cause of vision loss. Classical clinical signs are visual field defects, dyschromatopsia, and abnormal pupillary response. To anatomy, optic nerve is a paired nerve which carries visual information from the retina to the brain. It's 50 mm long. It is divided into 4 segments: intraocular, orbital, intracanalicular, and intracranial, respective lengths of which are about 1 mm, 30 mm, 6 mm, and 10 mm. Coming to the embryology, it is developed from optic stalk during the 7th week of gestation. Optic nerve contains approximately 1.2 million nerve fibers. It is covered by myelin produced by oligodendrocytes. It is covered by 3 layers of meninges. This is a picture showing the development of the eye. Aims and objectives: to study and evaluate various optic neuropathies and etiological factors leading to optic neuropathy. Materials and methods: a prospective clinical study was carried on 50 cases of optic neuropathy who attended to the Department of Ophthalmology in a tertiary care center from June 2022 to March 2023. Inclusion criteria. All clinically established cases of optic neuropathy
Excuse me,
are
Dr. Bhavna.
included.
Dr. Bhavna, just 1 minute because the slides aren't moving. Just 1 minute.
Should I start or continue? Continue.
Yeah, you can start.
Introduction. Optic neuropathy is one of the commonest cause of, sorry. Optic neuropathy is one of the commonest cause of vision loss. The classical clinical signs are visual field defects, dyschromatopsia, and abnormal pupillary response. Coming to anatomy, optic nerve is a paired nerve which carries visual information from the retina to the brain. It is 50 mm long. It is divided into 4 segments: intraocular, intraorbital, intracanalicular, and intracranial, the respective lengths of which are about 1 mm, 30 mm, 6 mm, and 10 mm. Coming to embryology, it is developed from optic stalk during 7th week of gestation. Optic nerve contains approximately 1.2 million nerve fibers. It is covered by myelin produced by oligodendrocytes. It is covered by 3 layers of meninges. This slide shows the development of eye. Aims and objectives: to study and evaluate various optic neuropathies and etiological factors leading to optic neuropathy. Materials and methods. A prospective clinical study was carried on 50 cases of optic neuropathy who attended the Department of Ophthalmology in a tertiary care center from June 2022 to March 2023. Inclusion criteria. All clinically established cases of optic neuropathy are included. Coming to classification, based on the ophthalmoscopic appearance and etiological classes, it is broadly divided into ophthalmoscopic and etiological. Ophthalmoscopic, based on the ophthalmoscopic appearance, it is further divided into primary optic atrophy, secondary optic atrophy, consecutive ischemic, and glaucomatous optic atrophy. Based on the etiological causes, it is further divided into demyelinating, non-arteritic ischemic, arteritic ischemic, inflammatory, infiltrative, compressive, toxic or nutritional, hereditary, traumatic, radiation, and paraneoplastic. Diagnosis is done by the clinical history and neuro-ophthalmic examination. Investigations done here are visual acuity, color vision, visual field testing, laboratory investigations in case of nutritional optic neuropathy, optical coherence tomography, MRI, and electrophysiological tests. Results. This slide shows the etiology of optic neuropathy. Coming to discussion, in our study, the glaucoma was the most common cause of optic neuropathy, contributing to about 60% of the cases, of which 18 were males and 12 were females. Toxic or nutritional optic neuropathy is second common cause, contributing to 12% of the cases, of which 4 were males and 2 were females. Optic neuritis is the third most common cause, contributing to 10% of the cases. And traumatic neuropathy is the fourth common cause, contributing to about 6% of the cases. This is a picture showing glaucomatous optic atrophy. And this is a fundus picture showing the temporal pallor of the discs. And this is a fundus picture showing a patient who is using ethambutol as a part of antitubercular therapy. And this is a fundus picture showing a marked inflammation of the optic disc in the left eye. This is a fundus picture showing marked inflammation of the optic disc surrounding the optic disc and with the involvement of adjoining retina in the right eye. And this fundus picture showing the traumatic optic neuropathy. As a result of the traumatic avulsion of optic nerve, first picture is showing avulsion of the optic nerve associated with extensive gliosis, whereas the second picture shows traumatic optic neuropathy associated with the disruption of vascular supply of the optic nerve and the hemorrhage in the anterior optic nerve sheath. patients of non-arteritic anterior ischemic optic neuropathy had a history of hypertension. In studies like Macule et al. Have showed that hypertension is one of the risk factors for developing non-arteritic anterior ischemic optic neuropathy in the patients above 50 years. In our study, all the cases of toxic optic neuropathy has addiction history of tobacco and alcohol of more than 15 to 20 years of duration. In studies like Beckman, Honey, R et al. And Fowles discuss that addiction of tobacco and alcohol is a major risk for toxic or nutritional optic neuropathies. The most common visual field defects in glaucomas were arcuate or double arcuate scotomas. Various other scotomas are also seen. Coming to the conclusion, glaucomatous optic neuropathy is the commonest cause of preventable blindness in my study, amounting to about 60% of the cases. Toxic or nutritional optic neuropathy is the second commonest cause, highlighting the importance of evaluating the nutritional status and supplementing vitamin B12 or folic acid and thiamine along with cessation of smoking. A good clinical history, screening methodology supported by judicial choice of investigations and the knowledge of different types of optic neuropathies allows us to make correct diagnosis and early intervention to prevent further vision loss. These are my references. Thank you.
It would have been good if you could have mentioned some distinguishing features of each type, where the diagnosis is obvious like glaucoma or trauma, then it is quite clear. But other cases like nutritional and ischemic, if you could have mentioned a few distinguishing features, it would have been more interesting.
Is it only the history or any other specific finding for the nutritional optic neuropathy?
Along with other lab investigations.
Clinical features or any
Yes.
other? Just
Anemia
based
or
on history,
pale-
you diagnose them as nutritional or toxic neuropathy or any other findings?
Findings based on history and supplemented with laboratory investigations. Vitamin B12, serum folic acid, and HB percentage in anemias and all. Thank you.
Thank you, Dr. Bhavna. So I'll call Dr. Devika next. Thank you.
Good morning to all. My topic is for the paper Obscure Intracranial Pathologies Manifesting as Acute Acquired Comitant Esotropia, an experience at NARAYO in Telangana. Acute acquired comitant esotropia is characterized by sudden onset of esotropia with diplopia, often occurs in children, teenagers, and young adolescents, where there is after complete development of binocular function. We need to note that on motor evaluation, ductions and inversions are full and free, and hence we should not confuse it with the sixth nerve palsy due to its sudden onset. Usually there are 4 types, classified as Swan type, Burian-Franchetti type, Bielshowski type, and those caused by intracranial pathologies. If not classified, we put them under idiopathic. The purpose of my study is to report a series of cases of acute acquired comitant esotropia presenting due to varied intracranial pathologies and highlighting the importance of imaging, especially contrast-enhanced MRI, as a tool to identify intracranial pathologies presenting as AACE, especially when no other etiology can be identified. A prospective study was done where 23 patients of AACE were noted, 14 of which were male and 9 female, mean age being 16.6, and they were managed and evaluated between May 2022 to April 2023, of which Burian-Franchetti type was 1, Bielshowski type was 1, there was no Swan type, intracranial pathologies being 5, and the rest being idiopathic. I am talking about the intracranial pathologies here. The first case being of a 22-year-old female who presented with decrease of vision in both eyes and severe headache, was diagnosed as right eye acute acquired comitant esotropia. She had, on the HCRT, it was 10 degrees of esotropia on the right eye, and PBCT showed 20 PDBO. Extraocular movements were full and free. The CT brain was done. Ill-defined areas of hypodensity in the white matter of the right frontotemporal parietal lobe, likely tuberculoma was suggested, and it was advised to get a contrast-enhanced MRI. On the contrast-enhanced MRI, tubercular abscess was detected. CSF analysis was done, and it showed tubercular meningitis. Case 2 was a similar case of tubercular meningitis in an 18-year-old female who presented to the OPT with decrease of vision and inward deviation of eye since 2016. And she had history of tubercular meningitis, for which she had taken complete treatment. Again, HCRT was 15 degrees esotropia in the right eye. Extraocular movements were full and free. Squint correction was done, but since she had pale optic disc in both the eyes, only it was more of a cosmetic correction for her rather than a functional correction. HCRT was central in both eyes. The third case being a very important one of a 5-year-old boy who presented with inward deviation of right eye since 20 days with history of fever 20 days back. This is 15 degrees of esotropia seen in the child. On fundus examination, blurred disc margins with disc edema suggesting of papilledema was seen. Esotropia of 15 degree was noted. MRI brain with contrast was done, and it showed a suprasellar craniopharyngioma of 4.2 into 2.6 into 3.5 centimeter midline extraaxial multiloculated, predominantly cystic and non-enhancing suprasellar mass was seen, suggesting suprasellar craniopharyngioma. This is where we can see this. Case 4 and 5 are of women who had presented with acute acquired comitant esotropia, and the cause being idiopathic intracranial hypertension. This 33-year-old female came with headache, binocular diplopia, and recent onset of hypertension and diabetes. Rest of the history was negative. She had 15 degrees of esotropia. Extraocular movements were full and free. The MRI on investigation showed partial empty cella with no space occupying lesion and granulomatous changes in the parenchyma. Magnetic resonance venography showed partially hyperplastic left transverse and sigmoid sinus. She was treated and put on acetazolamide for 2 weeks and advised weight reduction, and there was resolution of the papilledema as well as the acute acquired comitant esotropia that she was complaining. Case 5 was a similar case of a 17-year-old girl presenting with 1 month of headache and double vision. She had papilledema and disc edema in both eyes. HCRT was 15 degrees esotropia. Extraocular movements were full and free, and she was further on investigating in the MRI, which showed prominent preoptic and peritrigeminal CSF in the nerve sheaths, mild flattening of the anterior pituitary gland, and they were all findings suggesting of idiopathic benign intracranial hypertension. The MRV also showed bilateral lateral transverse stenosis. Discussion, the above 5 cases are highlighting the importance of contrast-enhanced MRI, especially imaging in all cases of acute acquired comitant esotropia, especially where you cannot classify them on the basis of whether it was due to an occlusion or due to myopia or hypermetropia or any other of these classifications. Hence, to identify the pathology or to classify them, an imaging is required. And also, it will tell us about the need of a multidisciplinary approach to manage this condition. In my study, the incidence of intracranial pathologies was 5 out of 23 cases, which was 21.73. Sex distribution was 1:4 for male is to female. The youngest at presentation was 5. Oldest at presentation was 33. Brain tuberculosis were 2 out of those 5 cases. Idiopathic intracranial hypertension was 2 out of 5 cases, and craniopharyngioma was 1 case. I conclude by reiterating that acute acquired comitant esotropia can present due to numerous pathologies where be it physiological stress, hypermetropia, myopia, or just occlusion of the binocular vision. And though it being a benign condition, I reiterate the need for imaging, not only in cases where we cannot identify the etiology, but in other cases also, so that we do not miss on any intracranial pathology presenting to us as acute acquired comitant esotropia, so that we can manage them. And also my study does highlight that my RIO shows different causes of acute acquired comitant esotropia with intracranial pathologies as compared to the others seen in other studies. Thank you.
Dr. Devika, very nice presentation. I just wanted to ask, I think I missed it, why was AAC present in cases of benign intracranial hypertension?
Ma'am, we had not seen these 2 cases were presented last year. These patients only presented with diplopia, headache, and this one woman was obese as well, and she had recent onset of hypertension and diabetes as well. When she presented to us with diplopia, we were surprised as well. But because as a routine, we are kind of investigating all patients and sending them for a contrast-enhanced MRI, and because she had no myopia, no hypermetropia, or any other cause of occlusion or disruption of the binocular vision, we sent in for a contrast-enhanced MRI, and then we found out. It was not that we have not seen this before, but these were the 2 cases where we actually had no idea that idiopathic intracranial hypertension could also just present to us with acute acquired comitant esotropia.
Okay. That's interesting. I mean, we should actually find out the cause as to why benign intracranial hypertension is causing acute concomitant esotropia. So, Because that's something that's very new.
Yes, ma'am. These two cases are the ones we've been reported. We've not gone into the cause of why it was so, but we do need to find out about it.
But overall, a very, very interesting presentation, and
Were the cases treated? Most of them where they didn't have intracranial pathology. What was the treatment?
So if it was a case of myopia where there was undercorrection or they was not treated, so spectacles were given to them, or if hypermetropia was there, or if it was if there was no other cause, we have surgically corrected them, sir.
yeah, like I said, it alerts us to the possibilities of the large spectrum of cases